Hi, I'm Lindsay Mabry, and tonight I'm going to be talking to you about ARDS, sometimes called ARDS, but it really stands for Acute Respiratory Distress Syndrome. Anatomic alterations of the lungs. In appearance, the lungs of a patient with ARDS are heavy, red, beefy, or liver-like. The anatomical alterations that develop in ARDS creates a restrictive lung disorder. The major pathological or structural change from ARDS are interstitial and intra-alveolar edema and hemorrhage, alveolar consolidation, intra-alveolar hyaline membrane formation, pulmonary surfactant deficiency or abnormality, and atelectasis. Etiology and epidemiology. The most common cause of ARDS are sepsis, aspiration, pneumonia, severe trauma, massive blood transfusion, stem cell transplant, and drug abuse. ARDS usually appears within 6 to 72 hours after an inciting event and worsens rapidly. The symptoms are dyspnea, cyanosis, bilateral crackles, tachypnea, tachycardia, diaphoresis, and accessory muscles of inspiration. General clinical course is characterized by several days of hypoxia that requires moderate to high oxygen concentration. Patient's overall health status is fragile. Diagnostic criteria. Berlin definition of ARDS is used as a diagnostic criteria for acute respiratory distress syndrome. However, ARDS is a diagnosis of exclusion. The Berlin definition of ARDS requires respiratory symptoms associated with ARDS have manifested within a week of known event or worsened over the past 7 days. Bilateral opacity similar to pulmonary edema that appears on a chest x-ray or CT scan. The patient's respiratory failure cannot be fully explained by heart failure or fluid overload. Moderate to severe impairment of oxygenation must be present as defined by the oxygen tension to fraction of inspired oxygen ratio, also known as the PaO2 divided by the FiO2 ratio. Clinical manifestations for the physical exam, it is going to be an increased respiratory rate, hypoxemia, decreased lung compliance, stimulation of the J receptor. The patient's going to have anxiety, they're going to have an increased heart rate, an increased blood pressure, an intercostal retraction, and they're going to be cyanotic. Clinical manifestations for chest findings, they're going to have a dull percussion note, they're going to have bronchial breath sounds, and you're going to hear a lot of crackles. The manifestation for the radiographic findings, a chest radiograph is going to show increased opacity diffusely throughout the lungs because of the bilateral alveolar infiltrates that develop in ARDS. An increased radio density is seen on the chest radiograph. The more severe the acute respiratory distress syndrome, the denser the lungs become and the wider the radiograph. The lung may have a ground glass appearance, like I pointed out to you in the other x-ray earlier. And then I have some more x-rays. This is a CT scan of a patient who has ARDS. And over here, you can see all these infiltrates. The heart looks normal. Looks like a pretty decent x-ray based on positioning and everything. But you do see these infiltrates, and they do look like someone took a glass and just grounded it into a powder. Oops. And the general management, oxygen therapy is used to treat hypoxia, decrease the work of breathing, and decrease the myocardial work. However, refractory hypoxemia due to shunting can be present. Lung expansion measurements such as PEEP, which stands for positive end expiratory pressure, or CPAP, continuous positive airway pressure, may be used to offset alveolar consolidation and atelectasis. Mechanical ventilation protocol. Mechanical ventilation is usually needed to provide support, alveolar gas exchange, and eventually to hopefully return the patient to spontaneous breathing.